Thank you so much. Thanks to the conference organizers and thanks to you, Sean. I really have enjoyed watching the talks, and I'm really honored to be able to share my experience with you in education. I was interested to see as well some of the prior speakers talk about opportunities for educating people in their field, and many people mentioned virtual reality. So when I've talked about this in the past, some people have said to me, geez, I wish I had that when I was in medical school. And I hope that at least a few people in your audience will feel that as well. So let's just get started. Just as disclosures, I'm going to show a couple of virtual reality programs. The first is the Stanford Virtual Heart, which was built by the company called Lighthouse Inc., where I'm the lead medical advisor. This was sponsored by our Heart Center at Stanford and also by Oculus VR, which is a Meta program. And then there's two programs that were supported by the University of Michigan and by Nationwide Children's in Ohio, also created by Lighthouse. We don't sell the software. It's shared freely with people, which I'll get to towards the end, but just to let you know that I was involved in creating those. I wanted to kind of tell everyone the story of how we got started building VR for congenital heart disease. And if you really are honest about it and think about where all this started, it kind of started here back when I was a kid. Some of you may remember the Atari 2600, and this here is showing, this is Superman. So back, almost 50 years ago, this was state of the art. I'm not sure if you can hear that, but this is the state-of-the-art images and graphics, and this was kind of the best of what we had to offer for gaming. And pretty quickly, with developments and chips and game engineering, we got to this, which even this is somewhat old now, but you can really see, the difference in gaming from, a couple of decades really. The technology really advanced so quickly that it allowed for a much more high fidelity gaming experience that is really something that was amenable to medical learning and medical education. And so when I was maybe a few years into being faculty member at Stanford, it was very clear as we were educating trainees and learning from our faculty and learning from with and from surgeons that congenital heart disease is a special field, as all of us know. Because it's abnormal formation of the embryonic heart, there's kind of innumerable, countless variations. How many times have we all been in a conference where everyone in the room with a combined, say, 500 years of experience will say, I've never seen a heart like that. And so the variations are just really endless. It's also really, if you can go back to when you were a trainee, or if you are a trainee, you're living this now, it's really hard to visualize and understand. And it's really hard to get a trainee, to give a trainee, a bunch of two-dimensional pictures or structures, and to have them create a three-dimensional image in their head so that everybody understands what are we looking at this imaging, and what are the problems that this patient has. And so this is really kind of the inception or the reason why our VR heart, the Stanford Virtual Heart, was born a number of years ago. So I really see this as a combination of science and art, VR in medicine, and V-learning or virtual learning, which a number of people also mentioned earlier today that I think was interesting. On this side of the slide here, I'm not sure if you can see my pointer, but to the right is a pathologic specimen, which in some ways is the gold standard of learning congenital heart disease, but it's also static. It doesn't travel very well. It can be really hard over the years as it gets kind of degraded to see the anatomic structures and relationships. And it definitely has advantages, but there are other things that in the art of this topic that actually make virtual learning maybe superior. And the top left here, what you see is actually how our software engineers constructed the Stanford Virtual Heart that I'm going to show you in a moment. It was constructed in a program called Maya, for those of you who are either gamers or computer programmers. And one thing that was really cool about the development of these programs is that I was able to get on Zoom calls with them and actually in real time have them adjust where, make this valve a little bit bigger, make this VSD a little bit, more positioned this way, and the software engineers were really amazing and kind of went through a mini medical school in a very brief time when we were developing this. And when you put the art and science together, what you get is kind of the panel at the bottom, which shows the development of the VR model that I'll show in a moment. So just to go back to when, number of years ago when we were considering building this, when I was saying how it's hard to take two-dimensional pictures and kind of have people understand what congenital heart defects are, we took our engineers from Lighthouse, which is the virtual reality education company, and had them sit with our chief surgeon in a very complicated surgical case. And for the surgeons in the room, you may recognize what this drawing represents, but this was the representation that we got for a complex congenital heart surgical repair. And through a little bit more discussion and understanding, our engineers were able to kind of storyboard this and draw what this surgical procedure was, which is unifocalization of major aortopulmonary collateral vessels into pulmonary arteries. And then we were able to put some color on it and show the patches and kind of storyboard, like how would we want to show this to really to patients. This was initially how we got started with patients. And eventually we got to this model, which was kind of played on an iPad, which is now still readily available to people online, to explain to people what is unifocalization surgery, which is a common procedure that we do at Stanford, to show people how our surgical team approaches this, and have them to be able to have an improved understanding of the surgical procedure their children were about to undergo. It's still flat. It's on an iPad. It's a pretty good representation. We thought that we could do better. And that kind of led us towards these next developments. So when I came through after taking care of patients in the clinic and saw that flat representation, this was still how I was representing to my patients who were in the cardiovascular intensive care unit, how I was representing to them a single ventricle heart, a single pulmonary atresia intact ventricular septum, and representing 3-stage surgical palliations, drawn on a whiteboard. That really probably isn't fair to offer that to families as kind of an explanation for what their surgery their child's going to undergo. After we built the Stanford Virtual Heart, we were able to show them this. And so here you can see this is actually a mixed reality video that we have, where we have the people that are using the heart are also, you're able to see it as well. And you can see that they can really get a clear representation of the heart, of a ventricular septal defect, of a defect when it's closed. There's red blood cells that are oxygenated or deoxygenated. Just want to go through that one more time. So they can pull the heart apart into its pieces. They can take each individual chamber up to their face and investigate it, look at the different holes. This is a muscular ventricular septal defect. Really get a sense of where are the valves in relation to that hole. Where is the AV node, and why is heart block a risk for a ventricular septal defect repair? Where are the red blood cells that are already oxygenated coming back through that hole back into the pulmonary artery? So we took that development of the Stanford Virtual Heart, and I actually took it back to that patient that I showed a couple slides ago, and to that patient's mom. And I was pretty proud that the Boston Globe actually picked this picture up, because that's my hometown in New England in the United States. It was really amazing to see a family actually say, for the first time, I really understand my child's heart defect. And they were really able to interact with the Stanford Virtual Heart and get a much better understanding of their child's defect, and actually had some fun, interacting with the virtual heart as well. I didn't know that when we set this up, I didn't know that the mom was going to do this, but she actually brought those hand-drawn pictures that we had given her when her child was born. They were, 3 or 5 years old, probably 3 years old at that time. And our families hold on to these pictures kind of almost like part of their children's baby book, or like kind of these sacred texts that we give to them. And so we felt like we had made a little significant advance in educating our families. We do have to acknowledge, though, that it's a very powerful technology. If any of you have been in VR before, you know that in virtual reality, you can really impress people and be impressed very quickly, very clearly. There's a kind of a little bit of a dopamine rush that happens with it. And along with that, as well, is kind of information we know about the general hype cycle for emerging technologies, which kind of looks like this. So as you're developing technologies, this may be true for surgical procedures as well, or for other things in our field. But you start with an innovation, you get this peak of like, this is going to save everybody and be the best thing for every single patient. And then there is also, a little bit of a crash, this disillusionment, before you get to kind of a standard plateau. Um, we thought that VR, we were kind of here in the early adopters, and definitely felt some of that peak inflated expectation. And I think some of that has hit this trough as we've realized that VR is not really as readily available to as many people as many people had hoped. There are also challenges I'll discuss towards the end as well with distributing this, worldwide, because it takes so much computing power. But we think that we're making inroads to getting to a nice plateau where this can be much more user friendly across the world. Just to mention, if you look at, I did a PubMed search this morning. If you search for just virtual reality in the medical field, you can see that there's about 9,000 results in the last, let's see, 15 years, and about a third of those have come in the last 2 years. So it is really accelerating. People really are using this in medicine, a fair amount. As we shared the Stanford Virtual Heart with other academic medical centers and also training centers, some schools, even an art museum, we have now about 80 centers or 80 users across the world on 6 continents that are using it. And I think that's shown that we actually really can have people that have put in a little bit of effort and have some computing resources use this technology. But in order to address that hype cycle, we actually felt it was really important to not just have this be kind of an interesting, fun toy that sits in the corner and gathers dust, or that gets irrelevant, a number of months or years um, after it's kind of introduced to a medical center. We really wanted the people that we were sharing this with to study it and to show like, hey, does this really make a difference? Can people learn from this? And are people enjoying it? And so I'd like to share a few of those examples. There are others as well, but I picked a few that I thought were interesting. Tiffany Lim and a group at University of Michigan studied virtual reality, their curriculum of the Stanford Virtual Heart, in pediatric residents knowledge, and we're actually able to show that yes, pediatric residents can learn from this. The trainees in the VR intervention group got higher scores on a validated assessment that was published separately, and significant improvement, especially in visual spatial concepts, which we thought was actually really important section of their learning and understanding, because that's really what the VR targeted. We really thought that VR should be better for the visual spatial understanding of, for example, what does that anterior deviation of a conal septum really look like in tetralogy of Fallot would be one question that I think would be something that VR might be able to answer better than kind of flat representation or even CT scan representation of a congenital heart defect. Moving further, another group that we shared our work with in Wisconsin and also in Michigan, again, studied VR in pediatric students, pediatric clerkship students. So these are medical students as well. And actually found very similar findings. We had, 373 medical students. About half of those were in the intervention group, and the intervention group performed significantly better than the control group, who just had standard congenital heart disease education. And I should say that most of the studies and most of the target of our Stanford Virtual Heart has been for about that level for undergraduates, medical students, pediatric residents, pediatric cardiology fellows, some surgical trainees. I've had a number of people ask me if we train surgeons on the Stanford Virtual Heart. While we have people that can do simplified surgeries to understand the procedure, it's really kind of gone the other way, where I was asking the surgeons to help me represent the best anatomic models. And so this really isn't a surgical trainer, although we've had some trainees that have used it and have actually had really good experience with it as well. We had one group in Wisconsin as well, with led by Steph Handler, that had a very interesting use where they actually took it into their pediatric cardiology to adult congenital clinic and had their patients use it to see if they could get their patients to understand their heart disease a little bit better as they were starting to kind of take control of their own healthcare, and improve their understanding of their congenital heart defect. And again, we were able to show that these patients had excellent reports of feeling that was a good use of their time. They enjoyed it. They enjoyed manipulating the heart. They felt that it was helpful in understanding their heart surgery, and overall that we got positive reinforcement that the VR could actually help with the clinic visit in just about a 10 or 15-minute VR intervention. I want to move now just to show a couple of more recent developments. So the Stanford Virtual Heart, initially built in about, let's see, 2017 to 18, and then refined over the years after that. These next two that I'll show were built in the program called the Mach-3, which is the Michigan Anatomic Congenital Heart in 3 dimensions. In the last, say, 6 to 12 months, which show kind of both improved development in the VR software engineering, but also in that we were able to really integrate a much more rigorous protocol and educational script so that students and patients and people that are using the VR can really be led through a real curriculum, which lends itself much better to training and education and also testing. So let's see if I can show you this here. So here we have a representation of a normal heart where you can again expand the heart into its pieces. We can make the heart turn kind of into almost like a see-through glass version where we have the red blood cells going through. Again, we can jump into the inside the heart and see red blood cells. And then this is a representation of hypoplastic left heart, which was the main target of this study. You can see here showing the surgical repairs with the neo-aorta and the RVPA conduit, which I learned in Michigan usually goes on that side of the aorta, whereas I think that's not every center does it that way, but we can represent kind of pretty much anything that we want. Oops, just go back here, play this again for you. So stage 1 and then into stage 2, which they do a hemifontan, and then stage 3, which they do intracardiac fenestrated fontans, which we'll fly through in a moment here. There's the fenestration to the left, and you can see how this can be a pretty powerful representation to provide understanding for the 3-stage palliation. We also collaborated again with University of Michigan and Nationwide Children's, which is at Ohio State, which is an interesting collaboration, especially for this weekend if you're a football fan. They're going to play this weekend, arch rivals, but to create a tetralogy of Fallot heart, which I'll show you through here. And they really wanted to focus both on beginner and advanced models in the VR hearts, and to really show 4 different either palliations or repairs. Here's the anterior deviation of the conal septum, which you can represent nicely here. You can show different colors of red blood cells, both blue, meaning deoxygenated, obviously, red being oxygenated, and then purple, importantly, for this defect as well. And then multiple different either repairs or palliations. Here's the modified BTT shunt procedure, which in VR you can spend as much time as you want here, and it explains each procedure, including here's an RVOT stent for palliation for patients that aren't surgical candidates, or a PDA stent as well, since these centers frequently do that. Also, for surgical repairs, we have a valve sparing repair shown here with a supravalvular patch and then a VSD closure. And then I believe the next one after that is a transannular patch to show the opening of that pulmonary ring. And you can see the anterior deviation of the conal septum there. This hypoplastic left heart model was actually just shown in abstract form at the American Heart Association. If any of you attended that, excuse me, attended that meeting recently in New Orleans, which again showed that fellows in pediatric cardiology were able to learn about hypoplastic left heart using this VR model. And just some specifics on this study. This was 13 pediatric cardiology fellowship programs at major centers with a total of 56 fellows, so kind of across different institutions, and found that the intervention group scored better than the control group, and that the vast majority of them in the high 90% reported that it was easy to use and enjoyable and improved their knowledge base. So we feel like we have some solid data to show that this is a strong candidate for education for our trainees. Just to briefly touch base on next steps. So there is so much that you can do with virtual reality, especially as we get into the realm of artificial intelligence, which is a whole different talk. But we do have a very strong modeling program with Allison Marsden's lab here at Stanford, and have done some VR modeling of complex flow physiologies and put those into virtual reality. And we're still really at the beginning of seeing where this is going to take us next. I think at some point it would be kind of the dream would be to put something into virtual reality, do a simulated surgery to age that surgery, 10, 20, 30 years with artificial intelligence and machine learning, and to see which surgery does better. Is it this Fontan where the Fontan is offset a little bit from the Glen, or is it that Fontan where it's a Y-graft Fontan, and to kind of model that over time. And so these are all possibilities, I think, for the future. I want to just shift gears briefly from congenital heart training, just to show a couple of additional projects, just to kind of pique people's interest. I won't focus too much on them, but these are both videos showing VR CPR training that Lighthouse built with the American Heart Association. Where with a special mannequin that had a special chip implanted into the breastbone of the mannequin, and using virtual reality gloves, we were able to link the virtual and the real world, so that these students here are learning virtual reality CPR in the Los Angeles Unified School District in Southern California. And they're getting this real-time feedback on, excuse me, how deep their compressions are, how fast their compressions are, whether they're getting appropriate recoil, and again studied with the AHA and shown to be superior to just compressing on a mannequin. And the kids actually had a really good time doing it and learned a lot. And so these are the kinds of things that you can use virtual reality with the real world merging in kind of a mixed reality educational format that we felt were interesting. Just to show as well other areas where we've built VR, our fetal center came to us and said, we're having a hard time explaining to people the surgery for twin-to-twin transfusion. Could you build us something? And so they gave us scenarios and made us obstetricians for a couple of months, and we were able to build a VR program to explain to people how we do complex sclerosis or laser treatment for twin-to-twin transfusion syndrome. And this is used in the clinics in our fetal center. And then finally, we also have built a number of science applications. Here's one just to show you kind of a gamified version of cell biology, using the cell in virtual reality to, there's a mitochondrion where you're going to throw out some energy and it kicks out ATP. And this was really focused for high school students. I want to stop there and make sure that I can take a few questions. I really appreciate the opportunity to speak with you all. I've really been fascinated by the talks and so many amazing perspectives. I did want to just briefly touch on as a last last slide is I get this question a lot, is how can I get a VR program for my center? And I did talk a little bit earlier about how we have a number of people that collaborate with us. And so just to touch base, the things that you would need if you wanted to kind of use these tools, and I would be happy to facilitate that or to encourage that. Um, right now, we are somewhat cost limited, but I think there are improvements that are coming down the line that will make that a little bit more manageable. The virtual reality headset, the way that we had to engineer it, it works on this VR headset. That right now costs about $275 US dollars, including the link cable. And you need the link cable to get that to a VR gaming computer, like a VR laptop. You can't just use like the regular, you know, a regular laptop that you use to do a Zoom. It's just not strong enough. You need one of those that's the gaming chip that you really need to have, which are getting less expensive over time, but still represent a significant cost for many people. We are also currently working, so at Lighthouse, the company that built the Stanford Virtual Heart, we're currently working on getting all the software ported down so it can just be run on the VR headset, which would completely remove this gaming computer cost. And so I'm hoping that that's going to come out in 2026. We're actively working on that. You'll also need the Stanford Virtual Heart software, which we share with people so that they can use it. So if you already have a VR headset and a gaming computer and you want to use the Stanford Virtual Heart, then you can just email me at this email here and I'll send you a link so that you can download it. The one thing you will definitely need that is priceless in any currency is you need a VR champion at your center, which is that you need someone who's going to help to understand how to load up the technology, help to get people into the VR headset, help when the batteries die and it needs to be fixed, and to make sure that the software is updating, and to think about interesting and fun ways to learn and educate people and to study it so that you get kind of the best program that you can have. I think that's all that I have, and thank you very much for your attention, and thank you again, Dr. Setti, for the invitation. I really appreciate it. It's been really nice to speak with you.
David, that was amazing to look at what technology can do. Unfortunately, I did remember the Atari, so I think I'm aging myself a little bit. But I can only imagine having something like this very early on, because as a surgeon training, it's amazing how long it takes to actually understand the anatomic relationships when you're standing on the opposite side of the table in a little tiny heart. So, I could see this kind of application for multiple people, right? I think patients' families is amazing, right? You draw them the picture and they're kind of looking at you like, I have no idea what you're talking about.
Yeah.
So I think it's great for multiple applications. So thanks so much for showing this to us. And then, my guess is that your company is going to kind of keep working on this real time is that the plan?
Yeah, so currently the developments in the last year have been building of those last two. So that hypoplastic left heart, which is really kind of one whole module just around that one defect, that was built. And then the next one that was built was another whole module just around tetralogy of Fallot, around that one defect. Whereas the Stanford Virtual Heart was like a little bit more like 8 different defects that you can go into very briefly, but not kind of as broad. And then the next development that we're really working on is getting it so that it's all available, and that it's powerful enough all to run just on the headset, so that we don't have to use that laptop computer, to make it more accessible to people. Because headsets, the VR headsets, you can you can buy them off Amazon and they kind of arrive whenever, or there are grants that you can get that make it like manageable, so that you can come up with 5 or 10 headsets and bring them to a center and educate people, and maybe leave 1 or 2 behind so that people can use it. It's a little clunky when you have the expense and the upkeep of a laptop as well. So that's what our engineers are working on right now, is making it. The problem is there's so much data in the VR experience, that it kind of, the older version, it overwhelms the VR headset. So they're working on making that a little more accessible.
Wonderful. Thanks. We have any questions? I think Dr. Kalungos has a question.
Yes, very fascinating presentation, Dr. Axelrod. Really, I appreciate it. One question. Do you believe in the near future this technology will allow us to create a patient-specific virtual heart, or like the 3D printing virtual beating heart model?
Yeah, so that's a great question. So the question being, can at some point can we have patient-specific models? And you, I think, absolutely can. I think there are um, advantages and disadvantages to both of those. We kind of see this as almost like the 21st century version of Frank Netter, or at least that's what we were inspired to be, or we aspired towards that goal of like the updated Frank Netter heart, where it's not really any one child's heart. It's kind of a conglomeration of this is what a general VSD looks like. And in that sense, you can kind of control and create whatever you want from an anatomic perspective. You also can do some things with the computer generated heart that we built that you can't with, say, CT scans or representations of an actual heart. Like when you fly inside the heart that's still beating, the resolution is so much better because it's computer generated that it still represents that anatomic heart. When you do a patient specific heart, it gets very hard because there's not enough resolution to do a lot of the things that we wanted to be able to do with education. But on the flip side, what you gain is that patient's actual heart that you can relatively quickly get from, say, a 3D scanned model or a CT scan and port it into virtual reality and manipulate it and software engineer it so that you can do, see how surgeries look. And while I haven't personally been working in that kind of trajectory, a lot of people are doing that work, and it's really great work. And I think that field is definitely going to grow. I think it's only limited right now just by computing power, and that's getting better and better. And image quality, that you have to start out with really good images at the beginning. But if once you do that, yes, I think it's a great idea. And then there's also the prospect of combining both. So you could have, this over here is kind of a prototypical VSD heart that you can really manipulate, and over here is your child's specific scan, and this is how we're going to approach it.
Wonderful. Thanks so much again for joining us. It's really late there, but it was really great having you live. I think this is a hard presentation to probably see recorded, so we really appreciate you coming on live. Thanks, David.
Sure thing. Thank
Okay.
you so much.
All right. Take care.